Okay, good morning and good evenings for my friends. I'm PY Chou. Today I will present my topic, the title. Uh-huh. Okay, go on. Okay, so my topic is the orthodontics and orthodontic surgery treatment in the Treacher syndrome. As the aforementioned, the two speakers focus on the class 2 malocclusion management. Now I will share my experience in the treatment in the Treacher syndrome. So patient consent already obtained to show in this Chang forums. I have to introduce this kind of a congenital anomaly in this kind of patients. TSC is so-called Treacher syndrome. It's a kind of mandible facial dystostosis. So it's kind of a genetic disorder. So it is be shown as autosomal disorder, autosomal dominant, with involving in the TCOF1 genes. However, this is a very rare congenital anomaly. So Tassir, our mentor, already have collected some cases in his series. So especially in some of the rare facial cleft cases, he collected majority of this kind of patient involved in the number 6, number 7, and the number 8 cleft. In the number 6 cleft, the problem always focus on the zygomatic malar area. And most of this kind of patient will focus on the number 8 cleft. So that the lesion will focus on the frontal zygomatic area. So in the combination of the three different kind of number 6, 7, 8 to see, I believe this is a pattern of cleft base should be described as a Treacher disease. So as the bone deformity, so we will show some soft tissue deficits in this kind of patient, especially in the orbit or in the malar bone. So the orbit will show the lateral eyelid deficiency, will show the coloboma. And in the malar, will absorption or deficient or absence. So you will see the bilateral malar width is very short. And then will follow by the maxilla and the mandible. So some patient will show some nose protrude as well. Especially some cases will have some small ear or microtia presentation too. So in Nedigan textbook has shown, once the kind of baby was born, the first very beginning we have take care of his airway. So that means once the patient already be born or in the sonograph examination, some of the pediatric or some emergency, the staff should be standby to secure. Probably have some very severe obstructive sleep apnea will occurring. So that emergency will induce to the neonatal death. And once the patient already be secure and then grows up to the 3 or 4 years of age, the early mandibular distraction should be performed to elongate this area of the ramus, the lens, and then we'll hope in the future could reduce the anterior open bite. And once in the patient going to the primary school ages, the further bilateral mandibular distraction probably should be established as well to make a better occlusal planning, and all the alignment should be prepared. And then probably before entering to the adult stage, the coloboma, the microstomia, or some microtia reconstruction should be delivered. So in the textbook, the 4th stage is very clearly be determined. So in the early life, the functional emergency, respiratory distress, or cornea exposure should be repaired in the first time. And then in the 2nd year to the 4th year of the age, zygomatic maxillary reconstruction should be arranged. Following 2 years or 3 years later, the mandibular distraction should be organized to have a better lateral profile and to reduce the anterior open bite. And the goal is to bilateral elongate for this ascending ramus, the lens. And finally, probably the distraction osteogenesis should be reconstructed for the ZMC complex. However, some cases probably cannot have very good result after the previous have been discussed this kind of reconstruction. In the adult stage, probably we can offer some more advanced or some more aggressive procedure, including probably the level 3 osteotomy, and it will combination with some zygomatic bone graft augmented, and then with probably the two-jaw orthodontic surgery as well, to get the patient have a better functional daily life. So in our experience, Chang Memorial Hospital, in our past experience, we have some cases, just like I have shown in my slide. In the very first beginning, your patient will complain, or their parents will complain of bilateral zygoma atrophy. We will harvest the cavarium bone graft to augment the bilateral maxillary width can be elongated. And then we will follow the patient from the childhood to the school age and then to the adult age. So we already correct some patient so far already have a 20 or 30 years the experience. And this gentleman is the brother with my previous patients. So this is a Treacher calling family. So they both come to our clinic for the surgical intervention. However, based on their different demand, so some cases probably only need to restoring for their functional occlusion. However, some patients probably asking for some functional and cosmetic result for better lookings. So you can see in this patient, only the two-jaw surgery was performed to correct the malocclusions in his dentitions. So this is our Treacher column syndrome family. However, this sister very fortunately and luckily has completed her life and her family with 2 children, as shown in my photo, but they are all both the Treacher column babies. So in summary, in the Treacher column syndrome treatment in our center, we have divided in the 4 different treatment time. The first one is the newborn stage, then infant, child, and adolescent. So some key points should be focused, especially once in patient in the newborn stage, retro mandible, tongue drop, or tracheomalacia. This kind of problem should be resolved. And then coloboma, ZM atresia could be considered to be reconstructed as well. And in infancy, cleft palate will happen, or the hearing loss. We probably will need to restore this kind of functional problem with some hearing assistance. So some of patients will wear some like a Baha in our clinical follow-up. And then childhood, adolescent. In our center, we have some organized treatment for this kind of patient's demand. And then I will show one cases with the Treacher column syndrome in our center, combination with the orthodontic and the orthodontic treatment to restore her better facial profile and her better occlusal problems. So you can see these girls come to our clinic probably in the college stage. In the previous time, the patient will not suffer from any the cosmetic or some functional problem. However, he come to our clinic with her chief complaint is that is obstructive sleep apnea, because she always complained she could not sleep very well in the nighttime, and then he always complained he could not have a better bite for some food. So you can see from the AP view and the lateral view, the patient show a retruded mandible and with very short the nasal throat length, and you can see like a bimaxillary protrusion facial like it, and the patient wear a hearing Baha devices. From the lateral view, 45 degree, you can see from his teeth appearance, the patient already received the first premolar extraction already, and start to wearing the braces under the regular orthodontic treatment. And you can see the smile, some of the gummy smile presentation. And from the other side, you can see the same. So from the X-ray, from the lateral view and the AP view, you can see a very limited and a very small airway showing in this cephalometry, and the small mandible with a very short mandibular body lenses, and with protruded bimaxillary area, like a bimaxillary maxilla, or the retruded mandible. So you can see a very like a strong mid face, but she present a very smaller lower face. These 2 teeth was designed by the orthodontic doctor. We have do the extracted for the bilateral upper, the 3rd molar, as well as the procedure of the orthodontic at the same time. And because currently in our center, we always perform the 3D simulation as well under some the guidance of the software, so we can easily to know where is the pathway of the inferior alveolar nerve from the right side and the left side. So easily we can try our best to protect the soft tissue, especially for the nerve. Otherwise, the patient will complain of the lower chin, of the lip numbness. This is the combined CT to show the pathway of the nerve, the other side. So the simulation in our center will be completed by the doctor of the orthodontics. So this patient was be treated by the Dr. Emma Yu Jia. So by the courtesy, I will show some of the surgical plan by her. So this is the initial position of the patient to present the upper jaw and the lower jaw, and we demonstrated by different colors. So as for Dr. Emma's presentation, the plan, she designed in the upper maxilla into the two pieces, including the anterior segment and the posterior segment. And this is the final position. You can easily to see the upper jaw, the maxilla already be divided in the anterior and posterior part. However, the lower jaw, the mandibular, is be advancement by different dimension in the two both side. This is the maxillary movement as shown, and you can see we are ready to closures of the premolar and the space. The gap already be decided. After the procedure, we have to closure of this space. Actually, for the designment of the surgical plan in the maxilla, you can see a kind of a counterclockwise rotation of the maxilla, including the posterior and the anterior segment. The whole piece is a counterclockwise rotation. And in the mandible as well, followed by the maxilla, the mandible was designed as the MMC counterclockwise rotation as well, including the bilateral segment of the distal segment, downward and advancement. And the final touch-up procedure will be completed with the advancement of genioplasty. So all of these three is kind of a tripart surgery in our daily routine procedures in the Chang medical centers. So from this view, we have a plan in ourselves to know the right side probably with advancement of mandible is a 7 millimeter, and the left side is a 10 millimeter advancement. So kind of the MMC will be a little bit rotated, yaw rotated for these patients demanding. So final positions like has shown here. After we closure the bilateral proximal segment and to reduce the bilateral gap in between the segments, so this is a final software decision for the patients. Pre, and this is the post. And the pre and the post. Originally, the A and B the angle is probably around the 40 degrees. After the simulation, we reduced the angle into only 5 degrees. After the surgery, this is the software. 1 week after the patient receiving the OGS, greater enlargement of the airway easily be demonstrated here as the arrows. So expansion of the airway, I think, is our first target to treat for the patient to treat complaint. So I think there is a very great improvement. So once in the patient come to our clinic in the orthodontic, you can see in the 2018, very cloudy, misalignment and miss the orientation of the upper and the lower jaw. The teeth arrangement is not in a very good positions. After around 9 months times of the orthodontic treatment, as well as for 4 premolars, the extraction, so you can see the upper jaw and the lower jaw, the teeth, the alignment is much improved, and the lower jaw, the space in between the extraction site has been closures. So before the surgery, actually, why we need to do the 2 pieces of the maxilla. The first one, the purpose is to reduce the gap in between the teeth. And then after the procedures, 4 months later, actually the gap and all the contact of the teeth is getting better. And after the surgery, 5 months later, surgery after probably 10 months later, you can see the much improved than the before. Totally, the patient received around the 15 months of post-op the orthodontics treatment. So kind of surgery early procedure we perform to deliver to the patients to correct all the functional and the cosmetic result. So you can compare the first beginning in the low row and the final of the occlusal planning in the upper row. You can see the differences. This is the pre and the post. And this is the pre and the post. So actually, we can see the lower jaw kind of angle of a Poconian is much improved as the compared to the before. And then the bimastoid protrude of the upper jaw, the nasolabial fold already been reduced as well. And we do the genioplasty to enhance the lateral views, the looking, and become more harmony. Yeah, very luckily, I and this girl has been a very good friend, and we have some media to have some advertisement. Yeah, so this actually her story is very encouraging. So I'm so lucky to be a friend with her. So by the way, we can to see what is the difference in between the pre, immediate after surgery, and after debone. What is the story tell us? And then you can see the three different of the rotation of the 3D. Upper and lower jaws, the arrangement, and you can see the right side, left side, how much of advancement the mandible achieved, and how is the performance, the change of upper maxilla, the change. Of course, we have to know how much is the greater dimension of the enlargement of the airway become. So we're using the software to calculate how much is the real airway be enlarged. So in the first beginning, the patient has the greater dimension in the slice around the minimum axial area. The space is around 140, okay, millimeter cubic. And then after the surgery, and 1 year later, the minimum axial area already be enlarged to 246 millimeter cubic area. So patient tell me after the surgery, probably 2 weeks later, 3 weeks later, she will not to feel any of the obstructive sleep apnea problem when he going to bed. So this is the AP view of the airways calculation. We show it in the pink color. And this is the side view of the airway we show in the pink color as well. So you can see here, can see the lateral view from the a little bit transparent view. Lateral view can see easy to know the lateral profile from the left side, the very first beginning to the right side, has a lot of change, especially in the lower faces. So we can see again, pre-operatively and post-operatively, all of the change in the patient with the Treacher colon syndromes. So we can see the rotation pre and up. Okay, and as we can see another view to know how is the change of the mandible as well. Okay, so finally, I would like to share some story with this patient because her story encouraged a lot of this kind of patient with Treacher colon syndrome. They are willing to open their mind and to show their smile, and they will a little bit encourage other friends with this kind of diseases will come for help in our center. Yeah, I think actually this kind of patient has some mind problem, probably in her peers or in her working places. But after our considerable treatment and our long-time follow-up, I think all of that will help them to tide over in the future anytime they were difficult encountered. Yeah, okay. So take-home message is that I present the treatment of Treacher colon syndrome and how the Chang has done, and we have presented some out of our experience in the soft tissue and in the hard tissue as well. And then is the orthodontic and the orthodontic treatment, how to combination in the treatment of TCS. So this is my presentation of this topic. Thank you for your attention.